outside the box. And then give a little update about this late diagnosis. How many people here have heard about this? The working group paper came out past June. It was one of those huge landmark papers. But again, it's not something widely known at this point. So I'm just going to kind of get through just some stuff about dementia that really comes in handy when we're talking about Parkinson's, basal ganglia issues, but inevitably, when people live long enough, these things tend to come up. So this is kind of the focus of my clinic at Evergreen. It's a memory clinic, but I work in the movement disorder group there, as well as the MS Center, so the Parkinson's Center and the MS Center. And so I see a lot of folks with movement disorders. I also, that's half my time. My other half of my time, actually, I work in technology. I have engineering training, and I still do quite a bit of research. So I do that under the umbrella of these two organizations. So just to remind people, just to take a step back for a second, patients come in all the time, they have Parkinson's, and they will always ask you at some point, what's normal? Is this because of the Parkinson's? What's going on? And so just to remind you that, there is some decline, and keep in mind the y-axis is zoomed in, so it looks a lot worse than it is, but there's some decline as we get older, right? So things like your speed, perceptual speed, your spatial orientation, things like driving at night gets harder. But really, things like if you look across the board, verbal ability, number ability, and I'm really doing the math, like doing a little math test on MMSC or MOCA, that really shouldn't change. 80 years old, 90 years old, you should still be able to do your serial sevens. So I like to remind people, this is really more what's considered normal. It's not normal not to be able to do serial sevens, when you're 80 or 90 years old. And then just another reminder how far we've come. We have really sensitive markers now that help us detect and be more specific about the diagnosis earlier in the disease course, which fundamentally is important for patients, for social reasons, medical reasons, but also for research, right? For us to test new therapeutics. So keep in mind up here, right? Historically, we've really relied on some of those curves over to the right are things like hippocampal volume on MRI, basic MRI structures. Those can take, the x-axis doesn't have years on it, but we're talking 10, 20 plus years difference. And so now, and pretty soon we will have amyloid PET imaging approved by Medicare on the market. So the IDEA study was positive. So we're just waiting for it to go through, but it's coming. So you'll be able to order amyloid PET scans for Medicare patients. And then hopefully, private insurance will follow. But the point is, you can then detect pathology many, many years earlier. And you can see there are several examples there. So why bother? Why do I do what I do? I honestly, I'm never cease to be amazed how many times patients are relieved when I diagnose them with, unfortunately, neurodegenerative disease. They really want to know. I see a lot of patients that are, I've been diagnosed with dementia for years, or cognitive decline, but they don't have the specificity really helps them move on with their lives, helps them with planning. Many times there are genetic implications, so depending on the rarity of the disease, and that's a whole other topic. Sometimes I send them to the geneticist. And then for my interest too, it's really for research implications. The number of studies we've had where amyloid-targeted therapeutics, for example, are turning out not to be very helpful. Well, we look later and find out that a large percentage of those recruited didn't actually have what they thought they had. They thought they had Alzheimer's, and this is what ties into the whole late diagnosis. Many, many people with Alzheimer's turn out it's actually not Alzheimer's. And so, again, part of my public service announcement here. Keeping terms, I think, clear is very helpful. So in clinics, we see a lot of mild neurocognitive impairment or mild cognitive impairment, dementia, which is major neurocognitive disorders. That's a severity-based diagnosis, and often, our patients with Parkinson's or with really any cognitive decline, that's what they end up carrying in their chart. But that's not right, that's not very specific. And so then we get into the syndrome based on the left, bottom left there. That's when we're talking about primary progressive aphasia, dementia with Lewy bodies. Really, when we say Alzheimer's, almost always we mean probable Alzheimer's. So we're talking about syndrome-based diagnoses here. So late, which is the Limbic-predominant age-related TDP-43 encephalopathy, that follows under syndrome-based. And then they add the NC for neuropathology changes. So that's when you're really looking under a microscope. And so keep in mind, when you say Lewy body disease, frontotemporal lobar degeneration, we're really talking about what are we seeing in the tissue. And so that's just a small clarification I'd like to give. And then really, I think it's helpful. I try to put in all my assessments that sort of this 3-4 tier diagnosis. So I'd like to touch on severity, of course, but then it's always, fun. That's why we're here. We like talking about this stuff. I like to talk about syndrome and stage, and then, if you can, neuropathology. You can sometimes, intuit what the neuropathology is likely to be. Real quick, just pointing out, right, many neuropathologies can lead to amnestic syndrome on the left there, but AD neuropathology also has these other manifestations. So I end up diagnosing things like, I've had a number of posterior cortical atrophy cases in the last few months, and that's very often, visual variant Alzheimer's disease. So I try to get a little bit more specific, try to nail things down, but this is why dementia is so confusing, because there's different pathologies can cause different syndromes and vice versa. So the main focus I wanted to put on today was the late. So this TDP-43 encephalopathy, just a quick background. In the 90s, there was a lot of studies coming out showing hippocampal sclerosis. We got good at seeing that. We could see it on imaging, but we didn't know what was happening. And then come fast forward to mid-2000s, we started doing autopsies and understanding better that these were the people that had TDP-43 pathology. We found out that was the protein that was causing this. And then it's really turned out that this is not Alzheimer's. And this is what's crazy if you think about it. Up to 20 to 50% over the age of 80 of people, all people have this TDP-43 pathology. So this is a huge implication for how we practice, how we diagnose. And so a large number of patients with Parkinson's are going to have this pathology. I'm just quickly mention, 30 seconds, this patient that I had yesterday happened to be one of these rare cases where he was in the IDEA study in 2016, so he had the amyloid PET scan. He had a DAT scan, but I didn't have that. I think that was done at Swedish or Virginia Mason. But he had a SPECT scan showing, asymmetric basal ganglia damage. He has Parkinsonism, and that's all he's been diagnosed with for the last several years. And it turns out, let me show you real quick. So look at how, unfortunately, how bad his medial temporal lobes look, and his hippocampi. I mean, this is what we really assume is hippocampal sclerosis. But his amyloid PET scan being negative, this was one of those rare cases where I can say, wow, he doesn't have amyloid pathology. And I mean, I would have assumed this was Alzheimer's, but it's in fact not. Most likely it's this late. And this is one of those rare cases where it's more of a pure presentation. So I thought it was really nice to point out. But you can see over here, in terms of age adjusted, his hippocampus is quite damaged. He also doesn't have the sort of typical Alzheimer's medial parietal atrophy, or the precuneus we call it. Of course, he has a little bit of, maybe NPH, that's a whole other story, but it's hard to see. But I will say here, there's several aspects of what you'll see early. This is obviously advanced, but there's separation of the entorhinal cortex there from the tentorium. There is a widening of the collateral sulcus. These things tend to go in a pattern. So it starts there and then eventually loops into the hippocampus. And so you can start seeing these changes. I actually looked at his MRI several years prior, and you can start seeing those even earlier. So anyways, that's it.